Hello, friends, colleagues. I have to say that looking to all the presentations during today, it made me really proud that we really made such a good family actually during those 6 years. And on the other hand, a little bit sad because this is also the end of this project. So this roundtable today will really present again in a bit broader sense our experience in this joint action, how the implementation journey actually went along in the real time with real people, with real teams. So as we explained today already, we can do such pretty much big changes only if we work together. So also this presentation, this round, my colleague David Somek, and we cannot do anything without the technical support from Lyudmil and Rudiger and Zoltan and his team. So I would ask for the next slide, please. We, in our implementation journey, took the 7 steps you heard about in the presentation from Lyudmil's video. And actually we had it really logically planned, but we also had emotional parts during this implementation project process. So we would really encourage you to look to the CHRODIS website and take a look of the short version of this guide, what our experiences were in short. Next slide, please. You are also already aware that we took into account the 9 lenses represented with 9 criteria from the recommendations that were developed in the first CHRODIS joint action CHRODIS. And it was actually the baseline that was taken into account at each of the 7 steps of the implementation journey. It really made a few important changes to our implementation sites that our colleagues will share with you in just a second. Next slide, please. With this, I would ask Maria from Croatia to share with us a bit more about their implementation experience. Maria, please, and Lyudmil will take care of the slides for you.
I hope you can hear me.
Yes, perfect, thank you.
Great. So the title of Croatian pilot was Croatian Minimum Diabetes Data Set Implementation using CHRODIS recommendations and criteria. So the next slide, please. Here's the scope of our pilot. So the starting point of our pilot was the insight that patients with diabetes are not being treated by the same clinical standards and throughout clinical pathways providing similar outcomes. So we have concluded that they need to be treated more efficiently in order to postpone development of chronic complications and to optimize the usage of all available resources. On the other hand, we have realized that healthcare providers who are included in care of patients with diabetes are not using the same internationally accepted minimum data set and are not providing good quality data. They also rarely kept track of secondary prevention activities in diabetes. After all that being said, the goal of our intervention was to improve GP's awareness of the importance of diabetes monitoring. Next slide, please. Here you can see our results in numbers. MDDS usage among GPs increased after our intervention. Average number of patients with fulfilled minimum diabetes data set per GP increased for 52%. A leaflet for patients was published in Diabetes magazine and was also presented at Croatian Conference of People with Diabetes, and now is being printed in 10,000 leaflets are being printed right now. And work in progress is still harmonizing diabetes information systems and coordination mechanisms according to international standards, but we hope it's going to be implemented soon. And here you can see important results that cannot be expressed in numbers. These are results of our qualitative research. We have conducted semi-structured interviews with GPs about their MDDS usage. And part of this was also the education of GPs about MDDS. And during this, we have realized that most GPs have positive attitude towards MDDS, and they see them as reminders in regular monitoring of patients with diabetes. Next slide, please. This is how we have involved both patients and GPs in the creation of our pilot action. GPs were really important to our pilot action because they gave us feedback on their experiences and needs regarding MDDS, and they helped us to see both good and bad sides of MDDS. So they framed the direction in which to change MDDS. And both patients and GP representatives have participated in creating a leaflet about the importance of regular diabetes monitoring. They helped us to frame the information in such a way to strengthen patients' health literacy and self-management. Well, the aim of this was to educate patients on their rights and responsibilities. The next slide, please. And here, in the end, you can see what will stay live when joint action ends. Changes in MDDS, that's really important part of what will stay live. Also, albumin-creatinine index in laboratories on primary level of care is going to be introduced. Leaflets for patients, which goal is to raise patients' awareness on diabetes and self-management, and of course, we mustn't forget QCR tool, which is going to be disseminated and also used in other public health projects. So that's all.
Thank you very much. So this is a bit more about the Croatian experience. We will have the debate on all these experiences after we present the 4 more pilot actions. So now we go to Finland. I know that there is a combination of voice and picture and the video. So Idel, please lead us through the presentation of Finnish experience.
So in our pilot, Stop Diabetes, we culturally adapted a lifestyle intervention to prevent type 2 diabetes. Somalis have higher levels of type 2 diabetes compared to other migrant populations in Finland. However, there are no culturally and linguistically adapted materials for health promotion. We aimed at creating and testing a lifestyle intervention model for an immigrant population group. We also wanted to improve access to diabetes preventive services by an underserved population group. In addition, we wanted to increase awareness on diabetes risk factors and adoption of healthy lifestyles through culturally adapted promotion and prevention activities. We also did cultural adjustments to the materials. For example, due to religious reasons, we decided to exclude all dietary recommendations regarding pork and alcohol. We also had separate groups for men and women, and we used the mosque as a venue. In practice, we used the existing Stop Diabetes Type 2 diabetes prevention model for healthcare, and we used the QCR tool as a framework. We recruited participants based on the Finnish Diabetes Risk Score, FINRISK. The intervention itself consisted of 6 group coaching sessions and a Stop Diabetes web and mobile application. We had 24 participants at baseline, and almost all of them took part in the group sessions. On average, 50% of group sessions were attended by each participant. All the participants used the mobile application, and we actually had a positive increase in daily vegetable intake. We also had some important results that cannot be expressed in numbers. The participants were very satisfied with the conduct and the content of the intervention, and they actually expressed their interest to continue the lifestyle changes also after the pilot period. We also noticed that taking the intervention close to the people, into their own community and in facilities that they know, was very important for the success. We also noticed that the community and the volunteer healthcare students were enthusiastically participating in each step of the project. In terms of involving the target population, in the pre-implementation phase, we had working group meetings, and these working groups included members from the Somali community. We also had participating, volunteering healthcare students. And in terms of including the participants in the decision-making of the project, we discussed in the timetable of the group sessions, and we agreed upon the group sessions altogether. When the joint action ends, what will stay alive is the fact that we created a feasible model to provide prevention interventions to an underserved and hard-to-reach population group. We have also managed to culturally translate and adjust all the used materials. We are certain that the intervention model could be transferred to other immigrant communities, both in Finland and in other countries. Of course, this would require close collaboration with the target population and training of the implementers, but this is all part of the process.
Okay, so we are presenting the findings we got from our pilot, which was about developing a culturally sensitive intervention model to prevent type 2 diabetes in this case, but the same model could be applied to any chronic diseases which has a strong link to lifestyles. And actually the idea came from Edel because she had been having these health seminars within her own community, and then there she got this idea that as diabetes is so big problem within this community, so she would like to do something. And then we started working together and did some background work and so on, and managed to pull this whole thing through with thanks to CHRODIS Plus Work Package 7, all the help we got from there. And later on, if you could actually download the video and then put it into CHRODIS website, then it would be accessible also from there without any password. But anyway, so we were actually very pleased with how the project turned out. So like Edil mentioned in the videos, so the length of the intervention was not that, or it was not that long that we would have been able to see any changes in important clinical risk factors. But the participants were very enthusiastically with the project, so that was a good finding. And like Edil explained, the key was that to take the intervention close to the people. So the intervention was actually conducted in the mosque, where these people, or it's the place of their community, and in that way they were able to grasp the importance of prevention activities, because it was shown in our background interviews that especially people from immigrant origins, they tend to think that these kind of healthcare activities are to be taken when person is sick and not for prevention. So this was actually a very new concept for them. And so we think that our model could be transferred to other Somali communities also, to other countries, because we have all the materials translated. So they are now available and they could be used in other countries also. And why not to take the concept also other underserved population groups, other immigrant groups maybe. So if it's not the mosque, so what could be the location where people come together and where people coming from their own community could help the other community members to pursue healthier lifestyle. So I think this was a very important finding also for us.
Thank you, Jana. Now I will ask Lyudmila to go to the next slide, and I will have to excuse our Greek colleagues because they indeed have the corona situation in their hospitals, so they are all away, and they asked me actually to present their pilot. Next slide, please. They actually decided to work on a group of people having type 2 diabetes and hypertension, and to actually develop an educational model where they included patients themselves, but also doctors, nurses, and paramedics, so that they can really structure the education for that people in the way it was not structured before. The Greek has maybe a special context since there is a lot of care being delivered at the hospital level, so they have been building up the hospital level educational programs. Next slide, please. They included 19 health professionals and 60 patients, and us constantly is that this involvement of the patients in co-creation of this educational program was really not something that was in the Greek culture. So that it was really something different to their team and brought a different perspective to their team, also concerning other projects or approaches. They understood that using this approach that we all shared, so these 7 steps and quality criteria and recommendations, that the involvement of the stakeholders outside of this core clinical team is very important, and they found that approach to be really effective when you want to break the barrier between the politics and other stakeholders. Next slide, please. As already described, they did involve the patients as well as the medical professionals to design that pilot action. Next slide, please. What they really always were expressing is that this sustainability focus was really a good framework to frame the messages to other stakeholders outside of the hospitals, and that there is a broad support for this practice that they developed among those who implemented it, and that potential impact on the population targeted also was assessed. The continuation of the practice has been ensured through institutional anchoring, through the ownership by relevant stakeholders and the communities, and that it really offered to their environment state-of-the-art management of chronic diseases. So unfortunately, I will not be able to take questions regarding the Greek pilot, But what really we saw working with them, but also on the study visit, that the really broad involvement of the partners we in healthcare usually do not involve was there, and that the communication was very vivid and the outcomes are there. So with this, now we go to Serbia. Vesna, the floor is yours.
Okay, thank you, Jelka, and thank you everybody in this joint action plus CHRODIS Plus. As for us, it's extremely important, and we are happy and in a way grateful to Jelka and colleagues to be able to involve us at some point of the project in this train, which we are calling Train for Improvement of Diabetes Care in Serbia. So we gladly accept, and you see, and I would probably repeat for some of you, and was at our last work package session in September, something what you know. But we were glad to involve 25 of us, both professionals and patients, in this endeavor. And from actually CHRODIS Plus, and particularly from CQR method, let's say, recommendations, we learned how important it is to involve from the very beginning stakeholders and all of those who are interested in these improvements. By the help of the team in CHRODIS Plus and our work package 7, we posed specific objectives, and they were related, similar to other projects, to improve capacity of health system and competencies related to diabetes prevention at all levels, to improve practice at the basic primary healthcare level, which for us was a little stuck after, so to say, 1 decade late legislation changes, which somehow put a little in the corner diabetes care at primary healthcare level. Therefore, we like to revitalize it, and we used our working package 7 group to help us in this effort. And finally, we wanted to use action and our pilot action to install record because we were only at the beginning of this process. And on the next slide, you see, or this slide now, you see the main results. We are actually happy to fulfill our expectations and hoping to continue in our national environment, but also environment of Europe, with what we have achieved up to now. And the first, we are happy to have National Diabetes Center, which we installed for the first time during this pilot action. Consisting of 39 health professionals, many of them from academic environment, and ready and capable to deliver new competencies for diabetes. Then we were extremely happy to improve prevention in cooperation with our patients, because this joint action gave us another light and shape how to shape our practice, that we are not autistic, and that we do that together with our patients. And finally, within health information systems, also expectations are quite big, but hardly we managed to succeed. It is impressive, over 38,000 health records which are already built up, but more important than this 38,000 is practice, which is behind that, and which allows now to our physicians dealing with diabetes to update themselves at each moment about their patients' status, but also more patients themselves to follow up what has to be done in self-management of diabetes care. Finally, if we would like to show something what cannot be expressed, but now here are photos from the life of our pilot action, both with physicians, but also we educated over 360 health professionals, but also on the next slides you will see that we never forgot on the next slide, yes, that we never forgot our patients who are actually here. We are here because of them and not vice versa. And therefore, they were involved at the very beginning. For them, it was very complex to study QCR tool, but that was beneficial because they also realized that in order to improve system, you have to possess strong tools in your hands. And what will be left to, and particularly how the sustainability will enjoy the results of our pilot action, you can see from slides, but we can say it in one sentence that Jelka always advised us to be precise and short, that working in multidisciplinary teams and together with the community of patients and citizens can bring us to long-lasting results. And sorry, really, that this was in a way a repetition, as I would say repetition is as the mater of studiorum, as old Latin people all said long time ago. And therefore, I believe that this will not point, but we will have an opportunity to go together in the same train in some other joint action, or the same maybe, as we proved that it works, and it really works for environments which need this kind of approach. Thank you.
Thank you, Vesna, very much. Big success. And we will finish with the Slovenian experience. Denis, please, the floor is yours.
From Slovenia, on behalf of our pilot action team. In Slovenia, we were developing a model of integration across primary and secondary level of healthcare and within the community using the joint action CHRODIS recommendations and criteria. So the purpose of this pilot action was to develop a model for complex chronic conditions, and we grounded our activities in the case study of chronic wound management in the municipality of Novo Mesto, Slovenia. And of course, like every other pilot in this work package, we tested the usability of CHRODIS recommendations and criteria as an implementation framework. Maybe you can go to the next slide. So we really wanted to understand all the issues from different viewpoints that are present in the care for complex chronic conditions and especially for chronic wound management. And that is why we conducted a comprehensive baseline analysis using qualitative methodology. And this is how we identified systemic and background specific barriers and facilitators to care. And then during the implementation process, we also selected different patient participants, patients who actually have chronic wounds, and we conducted with them patient needs assessments, again, using the qualitative methodology. And with that, we analyzed their personal histories, different social and healthcare needs, and also we tried to understood the nature of interactions they have with the healthcare system. And last but not least, we also analyzed the clinical pathways for patients with the highest health needs. And the results suggest that there is high variability in access points and duration of the treatment process. You can go to the next slide. So we formed our activities so that they would correspond with different levels that should be taken into consideration when developing such a model. So we develop activities within healthcare, within social care sector, and within the community. Next slide, please. So yeah, our core result is the model of integration, which considers two essential elements in the reorganization of care. On the one hand, we have primary medicine teams at the primary level who communicate and report patients to the secondary level through a unified access point based on protocol of collaboration, which is adopted by the both levels. So the primary, where there is a community health center, and the secondary, which is a hospital level. No, please go back a little bit, just to, yes. And what is important here is also that family medicine teams foster collaboration with the community through health care promotion centers, which are being established across the country. And the second element is an introduction of care coordinator at the secondary level of healthcare as a single access point for patients at highest health risk. And what is important here is that the organization of care becomes more process-oriented. The care coordinator, together with a medical specialist, perform treatment plans and organize care and integrate all those different services and structures at the secondary level. Maybe you can go to the next slide, please. So regarding the patient involvement, we are really happy and proud to be having such a vocal patient representative in our implementation working group, who has been active through the entire implementation journey. We also try to open the space for patient participation using the patient needs assessments. There, the patients could express their views and experiences regarding care. And also, during the pilot action, we established connections with different patient organizations at the local community event. If you go to the last slide, so what will stay alive when this joint action ends? The national decision makers and institutions are a strong supporter of this pilot action, and there are prospects of further collaboration and working on the model, which could be developed even further and adopted to other settings as well. At the local level, there is also support among the implementers to test the model in practice. And at the national level, a work group for integrated care was established, and also some of our members of our local implementation working group are participating. And last but not least, we saw that the QCR tool is a good and appropriate framework, and as such, it will be adopted also in other EU level projects where our institution, National Institute of Public Health, is participating. So that is it on my behalf. Thank you.
Thank you, Denis. So these are the experiences, and I would really like to, before I give the word to David, leave the last word to Marina, my dearest colleague and my dearest friend from the CHRODIS family. Marina, please.
Okay, you can hear me?
Yes.
Yes. Thanks, Jelka. Thanks a lot for all the work you did in this period, and not only in this period. We have had really a great opportunity with CHRODIS Plus to build on past knowledge and activities we conducted together in the joint action CHRODIS to use the quality criteria recommendations in several countries to help addressing the challenge of chronic diseases. A very ambitious objective. To the same, CHRODIS Plus helped committing countries to strengthen international cooperation, including collaborative partners in support of national, regional, and global plans for prevention and care for people with chronic diseases. Working and collaborating together has been exciting, and it would have been perfect to be able to celebrate this conclusion face to face. But, you know, we must always be ready to adapt to changing situation. And this is an important feature also for the success of our work. I must say that it would be fantastic if our work could add at least one step toward changing the quality of care for people with chronic diseases. And of course, I would like to thank all the partners and all the people working together in all the countries that have collaborated to this work package. So thanks to you all.
Thank you, Marina, very much. And David, I'm sorry, but I'm leaving you with 5 minutes. I don't know what you can do in 5 minutes, but you are usually a magician, so please.
Yes, challenges. Yes, yes. It's funny. You know, I care a lot about food, so I use food analogies. I mean, this is such a rich dinner, you know, that it takes quite a lot to digest, and I think to try and do more things is just maybe an overload. I suppose it's the sort of time when you want to have a sorbet or something to lighten your palate, you know. And I was actually, if we'd had a little bit more time, I'd be very interested to know from the individual pilot sites, what was the most fun thing that they got out of it? And we got some very serious, important things, but it's always about the human experience of actually doing it, isn't it? I don't know, maybe we've got time. But I'll just try a quick tour de table of the people I know from the units. Idil, can you hear me? Or would you like to just say something very quickly? No. Okay. All right, I'll go around the table. Vajna, then. Would you like to say something? Sorry, am I frozen? I'm not. All right, let's. All right, come on. I'm getting stuck here. Ludmil, would you like to say something from EPF about how you felt about it?
Yeah, of course. Do you hear me well?
Yep.
All right. I must say that me personally and EPF have been involved from the very, very beginning in the project. And I remember when we started back in Vilnius, Lithuania. It was a journey, a very interesting beginning. Zoltan and Rokas were really telling us that by the end of this journey, we're all going to become one family. And I think that we managed to achieve this, that we, as diverse as we are, we managed to become one family and to speak the same language. And I think this language is the language of the QCR2, so to speak. That's a little bit of an inside joke, but I think it happened. I think it.
Okay. Dennis, what about you? What was the most fun thing for you?
The most fun thing, definitely face-to-face interactions. I mean, I had the opportunity to see the work at this EU or work package level and at the level of pilot action, and I was quite happy to see all this enthusiasm of the people that were included in this project. But what was the most fun thing for me was definitely the fact that like you could have at the same table a community nurse, a surgeon, a cultural anthropologist, a decision maker, a director, and we all discussed about integrated care. So I think this is something that was most fun for me.
That's great. Okay, what about someone from Croatia would like to say something?
Well, probably probably the most fun part were semi-structured interviews with GPs, where we could find out their experience with MDDS, and that was probably the most useful part as well. So similar like Dennis, this face-to-face communication with GPs, but also with all other stakeholders.
Yes, it's the human bit, isn't it, really?
Yeah.
Vajna, do you want to say something now?
Oh, yes, thank you, David. I would like, because Lyudmila actually reminded me that what was the most funny, that at the beginning we didn't involve patients at all. And Lyudmila asked during his visit, and Jelka visit Marina also, oh, where are the patients in this pilot? And we said, but we didn't think in that way. Okay, we will involve. And then, as serves are always as a kind of personalities who must prove that they are right in time and etc. Then we rush to organize the next research and included both qualitative and quantitative data, and also to bring on the table or around the table in this our team patients. And he suggested us to do this survey, which is now actually ongoing, and we believe it became a base for one PhD thesis. So we are very grateful to Lyudmila and also to Work Package 7, David. But it was funny at the beginning that we little forgot on the main stakeholders, patients.
Yeah. Well, that's great. I mean, I'm afraid it's really a shame. We've run out of time. I'd love to talk more with you about this, but I think back to Jelka to move us to the next session, I think, yeah?
Yes, indeed. I'm really happy that we finished with the funny parts of our work, and I encourage everybody to take a look at the CHRODIS website, look for the guide that summarizes lessons learned, including some of those mentioned as being the fun ones. And contact also us if you have some direct questions. We are available to you through the CHRODIS website. And please join the continuation of the final conference through the old link that we were using during the morning. And thank you to everybody who participated. Thank you very much.
Thank you. It's a pleasure.
Sorry to tell now, it's not just a nice plan.